to memorize. I will ask you to memorize what is the ulnar collateral ligament, radial collateral ligament. Those are the ligaments that are frequently damaged, that's why. So when I have you memorize something for a test, it's because it's something you will see in, hopefully not your kids, but in other people's kids, or on the news. That sounds terrible, right? But this is that ulnar collateral ligament that's torn. That's what's torn when somebody needs elbow surgery. Usually it could be a baseball player, a pitcher in baseball. It can also be a football player. They can get torn ulnar collateral ligament. And then they need Tommy John surgery, which is just a replacement. And we kind of talked about the coxal joint. Keep in mind, this is highlighted and underlined. Know what the labrum does in general. We see the labrum in the shoulder and in the hip. In both areas, it kind of keeps the head of that bone. Femur, in terms of the hip joint, the humerus, and for the shoulder joint. It keeps the head more stable, and it kind of allows you to wrap the cartilage around the nice round head, so then you have more stabilization. Now, because of the fact that this hip joint is a weight-bearing joint, we want more stability. Remember, balance between stability and mobility, always at balance. The more stable something is, usually the less mobile. So here we want more stability, so we have this transverse acetabular ligament. That's right. That's going to also, right here, wrap itself around the head and the neck. So then you can stabilize that joint. Then we have this, the iliofemoral ligament, that allows you to carry and transfer your body weight from your hip. Now when you are sitting down, all of your weight, all your torso weight is on your hip, right? It gets passed on from each vertebrae, then to the next vertebrae. So it goes from L1, you take your body weight, you pass it on to L2, then you pass it on to L3, to L4, to L5, and then you pass it on to the hip joint, right? And to the hip itself. So your hip and your lumbar vertebrae receives a lot of the weight and tension as we're sitting. That's why if you have back pain, sitting is usually very painful. So what happens when we stand up, we want to transfer your body weight from your sacrum, from your ilium, to the strongest part of the femur, the shaft. We do not want that weight to go to the neck and the head. Those are the weakest parts. They're very narrow. So what we do is have this very strong, thick iliofemoral ligament, and it allows you to transfer your body weight to the shaft of the femur right here. Talked about the ACL, PCL. Those are cruciate ligaments. They allow us to prevent forward movement of the knee, ACL, and then PCL prevents posterior displacement of the tibia. So then your tibia doesn't move too far backwards when you're walking. If it does, you can imagine what happens when it gets really bad. And every now and then you see some horrific football injuries, and those usually will tear both of these, ACL, PCL, sometimes all the collateral ligaments as well, right? And some of the meniscus. Those are usually devastating knee surgeries. It's going to take years to recover from, even now with the present state of surgeries. You can kind of see how the MCL, medial collateral, and the LCL, the lateral collateral, it is outside of the knee joint itself. So the knee joint is this area right here. The knee joint includes the ACL and then the PCL, right? It does not include the medial and the lateral collateral ligaments. Those are slightly external to the joint. We talked about the difference between sprain versus strain, and now we're going to talk about some of the diseases, all right? So one of the diseases we'll see is that as we age, our joints get worse and worse. Obviously, if you guys played sports, it's it's going to be accelerated, right? So it's always good to play, sports, but after a while, when you play a lot of sports and you play a lot of basketball, you play a lot of football, you run a lot to get in shape for those sports, that's a lot of damage on your knees and your ankles. Now, if you do physical sports like nowadays wrestling and MMA, you're gonna have a lot more on your shoulders as well. So there's gonna be a lot of wear and tear type of arthritis. And as we age, tissue repair slows. Rate of new blood vessel development decreases, meaning that it becomes harder to heal from damage. Articular cartilages wear down and the matrix becomes more rigid. As the cartilages wear down, now you have bone-on-bone contact. Usually when you tear cartilage, there are no nerve endings there. There are no pain fibers there. So it really doesn't hurt a lot when you rip the cartilage. What does hurt though, is now that you've ripped the cartilage, now it's gonna be bone on bone. There are a lot of pain receptors in your bones. So once they start rubbing together, that's when you see the massive amount of pain. Production of synovial fluid declines. Remember, synovial fluid is like the oil that we put in that joint to keep it nice and loose. Ligaments, tendons become shorter and less flexible, allowing us a decrease in range of motion. Just keeps getting better, right? So we're gonna see this all and everything we discussed. As we age, things break down. They slow down, they have a harder time repairing when they do rip and rupture. Muscles around the joints weaken, and we see decrease in activity, causing less flexibility and decreased range of motion. Now keep in mind, if you have elderly parents, if they were to fall and break their hip, when they break the hip, usually they're breaking the neck of the femur area right here, or part of the shaft of the femur. They're not really breaking the ilium area, right? That's a hip area. They're gonna break part of the femur. When that happens, and they're over the age of 75, the mortality rate is about 50%. So 50% of the people that break their hip from 75 to about 85, and 50% die within the first year, year and a half. About 5 to 10% ever recover the activity that they had previous to the injury. 5 to 10%. That's not a big, percentage. So what we gotta see is, we gotta make sure, if you have elderly parents, that they are protected from themselves so that they don't fall. Because sometimes your parents, and my parents, can be very stubborn, right? My dad does not like to walk with a cane, even though he has foot drop, which we'll talk about later. So you can imagine how hard it is in the middle of winter to walk. So let's talk about some of the diseases that we see. There's gonna be 4 of them I want you to know. Osteoarthritis, gouty arthritis, rheumatoid arthritis, and a little bit about this ankylosing spondylitis, right? So I'm gonna highlight this one since it's not for some reason. And we'll talk about the first one right here, right? Osteoarthritis. So osteoarthritis, degenerative joint disease. So when you hear of people having degenerative arthritis, this is it. This is normal aging wear and tear arthritis. This is stuff that happens the more you use it, the faster it breaks down. Usually there's no inflammation. So it's not like what we're gonna see here with rheumatoid arthritis. Look at how swollen these knuckles are. Look at how swollen the fingers are. That's inflammation. We don't see that in osteoarthritis. See that? You don't see the swelling and redness that we see in rheumatoid. Now, what happens? Only cartilage is affected, not the synovial membrane. Deterioration of cartilage produces bone spurs, which then restricts movement. So let's see what happens. Right here, these are your fingers. What happens with your fingers is that you start having a little bit of rubbing, bone to bone, right? As you start having that rubbing between the cartilage right here, what happens then is that cartilage starts to wear down. You can imagine if you're typing, right? And again, you don't need to have some very, very, heavy movements. If you type for a long period of time, you're gonna have those movements over here. You're gonna have the ligaments, and you're gonna have these articular cartilage start to wear down. As it starts to wear down, now you have bone on bone. And you guys have felt how rough these bones really are. When you look at it and feel a real bone, it's not smooth like we see in the plastic ones, right? So it's sharp. And as bones rub against each other, it starts to rip off flakes of bone tissue. And now it's no longer smooth, right? Now you still need to type because you still need to work. What happens? You just keep rubbing the bone to bone. Again, bone has lots of pain receptors. So as you keep rubbing it together, you have a lot of pain, and then the bones start to take out larger chunks of bone, and it becomes bone spurs. Those bone spurs can restrict movement because it can get stuck in between the joint. Then you can't move your fingers as much. The bad thing about this kind of arthritis, no good treatment. So there is no good treatment besides for taking care of the pain. That's it. Now, usually we can ask one or two questions. A good doctor will be able to tell which is a kind of arthritis you have just by asking questions. They shouldn't need an x-ray. They shouldn't need that kind of ultrasound. They should be able to tell just by questions, and then they'll use the x-ray, ultrasound, they use the lab values to kind of have the definitive diagnosis. So when patient goes to see a doctor, patient goes to an ER, one of the first things we do is listen to their chief complaint, and in my head, I'm thinking, all right, what are the possible situations? What disease can it be? Somebody complains of joint pain, right away, rheumatoid arthritis, osteoarthritis, gout. It can be, just musculoskeletal pain, as well as bone pain. It can be all of these that are part of what we call our differential diagnosis, possible diagnoses. Now I start asking questions, Does it feel better in the morning and worse at night? Or does it feel better at night and worse in the morning? Well, certain kind of arthritis gets better with use. So with osteoarthritis, when you're sitting there, and not using that joint over the course of the night, you're not typing, what happens? Well, you don't have bone-on-bone movement when you're asleep. So you don't have as much pain when you first wake up. So pain is better when you first wake up. And then you go to work and you start typing, and now you have those bone-on-bone movements. What happens then? Now the pain starts to come. And the pain gets worse and worse throughout the day. That tells us it's a sign of osteoarthritis. So a simple question like that can be definitive in my differential. Yes, it gets much worse at night, then it could be osteoarthritis. More common in older adults and athletes. Obviously, athletes have to run a lot. They need to jump. They need to do a lot of those movements daily, to play that sport, to get in shape for that sport. So you're going to have a lot more wear and tear arthritis as a result. Now take a look. This kind of, the fingers right here, they look, the capsule you can see. So you would think that this is swollen. No, when we see swelling, usually there's swelling and redness. That's an inflammatory process. That's what we see here. See how red it is? See how much more swollen these knuckles are right here? That's swelling and inflammation. In osteoarthritis, you don't see that much. Now, the next one we talk about is rheumatoid arthritis, which is right here. In rheumatoid arthritis, it's completely different than osteoarthritis. In rheumatoid arthritis, it can happen at any age. It is an autoimmune disorder from antibodies attacking the joints, usually the proximal interphalangeal or the distal interphalangeal joints. It can occur anywhere though. It can occur in the eye, it can occur in the elbow. Any place where you have any kind of fluid, the antibodies that we have in our body mistakenly attacks our own body and not any of the bacterium that we have. So that's what we mean by an autoimmune disease. Autoimmune disease, either your white blood cells physically attack your own cells. We see that in certain kind of thyroid conditions. We see that in MS. And we'll talk more about MS later on. In multiple sclerosis, our own body's white blood cells starts attacking our cells that allow us to activate the neurons. Right? Those cells we call myelin cells, right? Schwann cells. So same thing here. It's an autoimmune disease where your body's white blood cells produces this. An antibody is it's also known as immunoglobulins. Keep in mind, right? They're used interchangeably. Antibody, immunoglobulins, they mean the same thing. These antibodies are proteins produced by your white blood cell. Those proteins go into your bloodstream and they attach to any foreign antigen, any foreign bacterial, any foreign viruses. By attaching to it, those antibodies neutralizes those viruses, so then they can't get ill. Do you guys know with Ebola, how we started treating Ebola? Remember, Ebola before this last outbreak, right? When we saw it any other time, the mortality rate was astronomical. 90-95% mortality rate. So you would get it, 95% of the time you're gonna die. That's crazy, right? This last time it went down to 35%. 35% doesn't, sounds like a big decrease. But remember, we think that coronavirus, right now, we're gonna see a drop in it, is about less than 1% mortality rate. So what are we gonna see? How come it dropped from 90 to 35? Is because we started having treatments for that disease, for that illness. And what was the very first thing they did was easy, right? The people who survived, they were able to fight off that infection, right? They got Ebola, they fought it off. That means that they were able to have white blood cells that cleared that virus. They were able to have white blood cells that recognize it, forms antibodies to the Ebola virus, and they survived because those antibodies protected them. So what do? The people that survived, we took their blood and, right, we took out those antibodies and then we gave it to the people who were sick. Those antibodies then started attaching to the Ebola virus in the patient who was sick, helping them clear that virus as well, helping them survive that illness, right? Now, we're gonna see, one of the things we will see is they will try to do the same thing. People who survive, we take their antibodies and then give it to people who are really sick. Now, we'll only do that if people are really sick, right? Most of the coronavirus that we're gonna see is gonna be just very flu-like. It's not worth risking somebody's antibody being put into your bloodstream for that, right? Now, if you're really sick, yes, we might have to do that then. If you are old, you already have lung disease, right? You already have autoimmune disease as well. You might not be able to clear and get rid of coronavirus. So what they could do in the foreseeable months is actually filter antibodies of people who did survive. And those antibodies of the people who did survive should recognize coronavirus. And what we're gonna do then is inject, right? Clone those antibodies, inject it into the real sick patients, helping them clear the illness as well, right? It's kind of cool, kind of novel way of treating it. Now, rheumatoid factor, RF factor, or ANA, autoantibody antigen, right? This rheumatoid factor is an antibody that's tested for in the lab exams. Again, we can usually tell by an x-ray, we can usually tell by a history and physical, whether it's rheumatoid arthritis or osteoarthritis. But to definitively know, we'll do a lab value test. We'll take blood out and people with RF has this autoantibody in them. Cartilage is attacked, massive inflammation, massive swelling, massive pain. There's so much inflammation that if you take a look right here, this is your metacarpal bone right here. First, second, third, fourth, fifth metacarpal. This is your proximal phalanges. This is your intermediate or medial phalanges. All right, between the phalanges, you should see a black kind of line right here. See that? Here's that line. That means that there's still a joint there. You still have good, easy movement because there's space for the two bones to move with each other. Line right here, over here. Take a look right here. There's no line. It's completely white. What does this mean? That means that this area has been attacked so much by my antibodies that instead of just having an open space, bone started to fuse these two bones together. At that point, he or she will not be able to bend their finger like this anymore. They'll just be able to do this. That's it. So when they want to grab something, they'd have to grab it all together, right? Or they're going to have to grab it with just one or two of their fingers. They won't be able to move the middle finger or their index finger separate, right? The only movement they can have with the fingers is between the phalangeals right here. And even then, you can see this area right here, right? Notice that you don't see as much black right here anymore, right? Well, that means that this joint itself right here has started fusing as well. So eventually, that fusion is the last step. With rheumatoid arthritis, you see lots of pain in the morning, right? When you wake up, you haven't used that joint. The joint's very creaky, very, very tight. So it hurts when you first wake up. As you start to move around, the synovial fluid in that joint starts to be, right, kind of loosen that joint up so it feels better over the course of the day. Now obviously it's never gonna go away, so it just gets better during the course of the day. So here's a picture of what we call swan necking, right? This is swan necking right here, where the fingers move laterally right here. Right? Usually when we see the swan necking, is a sign that you have fusion of one or multiple joints here. That swan necking, look at how mean these knuckles look. Right? Usually that's a sign of fusion there.